May I start?
Yes, Dr. Pooja.
Yes, sir. Very good afternoon to all. TMG disorders can be a dilemma and put forth challenges in clinical management of patients suffering from TMG disorders. We have with us today Dr. Manish Katyayan, who will talk on TMG disorders, a clinical perspective. And our chairpersons for the session is Dr. Lakshman Rao Batla and Dr. Rekha Gupta. So, Dr. Lakshman Rao Batla is currently working as the Director PG Studies, Professor and Head in the Department of Prosthodontics at Lenora Institute of Dental Science, Rajamundry, Andhra Pradesh. Sir has completed his BDS and MDS from GDCH Hyderabad. He has more than 87 national and international publications in various reputed journals to his credit. Dr. Rekha Gupta is currently working as Associate Professor and Head of Department in Maulana Azad Institute of Dental Science. Ma'am has completed her BDS from MAMC Delhi and post-graduation in prosthodontics from AIMS Delhi. She has more than 30 publications in national and international journal to her credit. She has conducted many full-day workshops and hands-on courses, lectures during her conferences and PG conventions. Ma'am actively involved in academics, administration and research work, and her special area of interest is maxillofacial prosthodontics and full mouth rehab. Now, I would like our chairpersons to introduce our keynote speaker.
Thank you. Am I audible?
Yes, sir.
Yeah, it is always a pleasure to introduce someone known to you. If that person is your friend, then that will give immense pleasure. Now I am facing the same. Good evening, everyone. Hope all are in good health. Let me introduce my friend and today's speaker, Dr. Manish Katyayan. Dr. Manish did his bachelor degree from COTS Manipal and master's in prosthodontics from RV Dental College, Bangalore. Perhaps he is one among very few prosthodontists who pursued PG diploma in quality management and accreditation of health core organizations. He is presently working in GMER Medical College Civil Hospital, Gandhinagar as assistant professor. Dr. Manish is executive committee member IPS and also serving as secretary IPS Gujarat State Branch. He has many national and international publications in his credit. Dr. Manish has also very active and conducted many courses and workshops in various IPS conferences. Today, he will enlighten us on TMJ disorders, a clinical perspective. Ladies and gentlemen, myself, along with my co-chair, Dr. Rekha Gupta, Madam, welcoming Dr. Manish Katyayan. Manish, please take over.
Thank you, sir. Thank you, sir. Hope I'm audible, sir.
Yeah.
Always a pleasure to meet you, sir. And good afternoon, Madam Rekha, Madam. I'll just share my screen, sir. Thank you for the warm introduction, sir. Just to update you, I rejoined Government Dental College and Hospital, Ahmedabad, few days back, and working there now in Department of Prosthodontics. I'll start with my presentation. The topic for me today is TMJ disorders, a clinical perspective. Good afternoon, everyone. We have all read about the complexities of this disorder affecting the temporomandibular joint. In reality, it's really a very painful and frustrating condition, which needs to be understood from the clinical perspective. And just to update you all, it is almost the second most common musculoskeletal condition that affects the daily activities, psychology, and quality of life for our patients. The first one being lower back pain. So today, in this presentation, I'll be dealing with few cases and how exactly our postgraduate students can manage those cases in a very simple manner using basic technology and equipments that are available with us in almost all departments. As all of us know, the TMD complex functions with a delicate interplay between three major components, that's temporomandibular joint, the muscles and ligaments, and the teeth and supporting structures. So any disharmony between these three can progress to a temporomandibular disorder. We are all aware of the TMG anatomy comprising of bony, soft tissue, and muscle components. Each of these has a vital role in optimal functioning of TMD. As mostly all of us know, this disorder has been addressed by many terminologies since 1930s, when it was not fully recognized or understood. But since then, many terms have been adopted and abandoned, focusing on a single etiology, single treatment approach. Currently, as all of us are aware, the all-inclusive umbrella term temporomandibular disorder is the widely accepted terminology. Now coming to what exactly causes a TMD. For a specific event to result into a TMD, the individual must have certain predisposing factors which make him more prone to get affected. For example, the same event may not result in TMD in all individuals. So these are the risk factors, and these risk factors might be structural discrepancy, physiologic or pathological conditions, or behavioral, you can say, mismanagement or disorders like stress or any noxious habit that's there in those patients. And sometimes we see, as you can see here, many other systemic problems come along with these disorders. Like I can show you here on screen, this patient came to us with TMD disorder. We evaluated him and then we found that there might be some sinus involvement also. So along with our normal CVCT examination, we advised him to go for maxillary and sinus evaluation also. And we found out that there were sinus polyps on right side and some sinusitis symptoms were there, and it could be seen in CVCT also on left side. As you can see here, this polyp is present and some sinusitis was present on left side. So we always have to remember that when the patients are coming to us, it might be a combination of our TMD problem along with other problems. Coming to the precipitating factors. Precipitating factors are the initiating factors that will cause the onset of disease. Anything from trauma, stress, infection to a faulty restoration by a dentist are few examples. They are also known as triggering factors. Perpetuating factors. Perpetuating factors are nothing but maintaining factors. They are they interfere with the normal healing of our joint and they enhance the progression of temporomandibular disorder. At times, genetic, developmental, or environmental factors also play a role. So we have to be aware that the main aspect of successful management of TMD depends on identification of these factors and then later controlling them. The wide spectrum of various subcategories is reflected in this classification. As we can see here, there are countless classifications and one such is this Bell classification. This was adopted by ADA also. This divides all TMDs with similar characteristics into 4 broad categories, as you can see here, that is masticatory muscle disorders, temporomandibular joint disorders, and little less common ones like chronic mandibular hypomobility, which includes ankylosis and muscle contracture, and obviously growth disorders that we normally face in such patients. Another widely accepted classification is that of AAOP. This has wide clinical uses and is simple to follow. As you can see here, it can be just divided into TMJ articular disorders and masticatory muscle disorders. So for our users and our day-to-day practice, what we normally follow and do is we just divide it into 3 common types. That is derangement of disc condyle relationship, structural incompatibilities, and inflammatory disorders of joint. So here in this presentation, in brief, I'll discuss some classic cases, very simple ones and the common ones that we all of us face in our departments, and within our limited resources, how we can manage them and provide relief and comfort to our patients. We'll little bit talk about the, give me 1 second, I'll share the sound. So deviation of mandible. Deviation of mandible is the movement when the mandible moves away from the midline and it comes back to the center. So it moves away and then it comes back to the center. And it is described as a, normally either we follow a C pattern or S pattern. So we have to see while evaluating the patient, see, it comes back to midline and then it deviates. And again, when it goes to fully opened position, it again comes back to midline. So that's deviation. Now I'll just show you a case where we see deflection. Is the video sound coming up? I'm not.
No, the sound is not there, Dr. Manish. We can see the video, but it's without sound.
Give me 1 minute. Anyway, I'll speak, no problem. So deflection of the mandible is the movement away from midline during opening, and the mandible doesn't come back to center, like that, without returning to center during the movement. If I show you in this video, the deflection of mandible is very pronounced and exaggerated. As you can see, when she is opening mouth, it's clearly deviating towards one side. So here you can suspect a particular diagnosis, that is, the right side of condyle of this patient is moving freely, whereas there is some disturbance with left side condyle to move it forward. So we suspect left side temporomandibular joint articular disc displacement. Now we assess it later whether it's with reduction or without reduction. See, it's moving towards one side. So it's a severe case of mandibular deflection that we see in such patients. In this case, there are multiple missing posterior teeth. Chronic loss of posterior occlusal stops result in occlusal interferences of remaining teeth, and inadequate tooth support to hold the mandible in a stable position, as you can see here. This patient came to us with temporomandibular joint disorder. She had severe pain on both sides, but we can see that the teeth are unable to hold the mandible in a stable position, and this has led to orthopedic instability and consequent TMD. And there is mandibular deflection also. So we all should understand that long-term overclosure and loss of physiological VD can contribute to subluxation, and sometimes we have also seen dislocation in severe patients. Now coming to a little bit about the radiographical evaluation in such patients. When we subject these patients for radiographic evaluation, we see many changes in the condylar head. There are various types of notching, grooving, remodeling changes might be present, or some resorption changes also we see. Sometimes cysts and osteocytes we see. As you can see here, see, bone-to-bone contacts have started, different shapes of condylar head that you can find. So we have to really think what exactly is happening in relation to the condyle and the articular eminence. We have to evaluate any changes, erosive changes that is happening. As you can see here in this X-ray, see, mild erosion you can note on both condyles. So such changes we need to evaluate. This is what I was talking about, severe erosive changes. upper surface of the condyle seems to have totally eroded. So such patients start giving you complaints of crepitations while the patient is opening his mouth or doing any functional activity. And here, as we were talking about some of the articular changes and changes in the shape of condyle, you can see in this CBCT how prominently there have been changes. So we have to be aware of these changes that are happening in these patients. Second most important thing is we have to understand the extent of movement, till what extent our mandibular condyle is moving along articular eminence. Because as you can see here, its closed position, the left condyle is in fossa, but the right condyle is coming much ahead when the patient is in completely closed position. So then we have to accordingly evaluate the patient. Here you can see that this is closed position, the condyle is in fossa, but when the patient is opening mouth, it's going much beyond the articular eminence. There can be many reasons why exactly these things happen. Loosening of your ligaments, your capsule might not be so tight, the muscles are not able to support your joint. So these subluxation changes might be coming because of that. And when these subluxation changes are not treated, this subluxation leads to dislocation. That's what subluxation changes we were talking about. As you can see here, the mandibular condyle goes much beyond the articular eminence, and this is what is called subluxation. It's not staying within its limit and it's going much ahead. So ultimately what happens is, as you can see here, the bone-to-bone contact starts coming. The articular disc gets displaced and bone-to-bone contact starts. And once that starts, there will be erosive changes that will be coming in. So in these cases, we have to stabilize the condyle in a stable position using any of the prosthetic measures or putting him on rehabilitation. And then we have to give him time, even the muscles, to get adjusted to a particular stable position and proceed with the patient's follow-up. MRI imaging is very important, especially when we are talking about articular disc displacement, because whatever clinical judgment we do, ultimately the final diagnosis regarding disc displacement has to come with MRI evaluation. MRI, little bit if we try, we can start reading these MRIs, and then you can clearly evaluate the condyle, the disc position in various angles and various sections that are available. CT scans definitely from various sections will give you a very clear idea about how exactly is the shape of the condyle, whether there has been a close contact between the articular surfaces, and are any organic or bony changes seeping in along with these patients. Coming to a little bit about the methods of management. The main aim in deciding treatment protocol in such patients is the chosen therapy should provide three things. First is long-term relief for patients, because patients are coming to you with some problems. So we have to take out a treatment plan which will provide them long-term relief. And whatever treatment we do has to have some scientific basis. So always try to follow a treatment protocol which is evidence-based. And thirdly, looking at our scenario, almost last more than 9 years, I was working in a civil hospital, that's a district hospital. So we have to look at the patient's economic status also. So always we have to plan our treatment in a cost-effective manner. The first step is symptomatic care, that is soft diet, NSAIDs, moist heat pack, alternating with ice, voluntary disengagement of teeth, and further treatment modalities can be definitive or supportive. Now, coming to the definitive treatment modality, it identifies the disorder first and treats cause of disorder, whereas reversible occlusal therapy achieves this by means of splints, and irreversible occlusal therapy involves altering occlusal surfaces of teeth or restorations by selective grinding. So we have to understand that occlusal therapy can be reversible and irreversible. Reversible will be using our splints, and irreversible will be occlusal therapy. Emotional stress therapy and behavior management of patients also play a very important role in these, along with some pharmacological agents like physical therapy. I just missed physical therapy. I didn't tell. Yeah. The physical therapy, as you can see here, exercises and restricted use and physical therapy, it's an adjuvant to definitive treatment. It involves thermotherapy, coolant therapy, and for relief from dysfunction, patient is advised to restrict jaw opening and exercise, as resistance exercise and passive muscle stretching are normally prescribed for such patients. Now coming to splints. Whenever a splint therapy is indicated, after it is determined whether to go for a stabilization splint or anterior repositioning splint, there are a few major decisions to be made. Whether we should go for full or partial splint. Generally, full coverage splints are preferred, as partial splints lead to cause supra-eruption of uncovered teeth in that arch, and then that will lead to problems later. Coming to maxillary or mandibular splints, splints can be given either in either arch, depending upon the aesthetic requirement in case of a daytime splint. We also prefer splints in such arches where there have been loss of teeth. Because if teeth are missing, we replace those teeth or give us acrylic base in those arches, so that the other arch will be stabilized with that. If the patient is having nocturnal parafunctional habits, or when the patient wakes up in the morning with worsening of symptoms like pain or stiffness, then we must opt for a nighttime splint, so that rest will be provided to muscles and periodontal ligaments. Initially, patient can wear them and become accustomed to it during daytime. And once they are comfortable, it's better to have, they will adhere better to nocturnal wear. Coming to the duration of wear, normally stabilization splint should be initially worn for 24 hours per day, so that the jaw positions get stabilized, and then gradually patients can wean it off. Normally 3 to 6 months of wear is advised for such patients, but then again we have to constantly keep evaluating them and proceed with that. We will discuss the specific treatment modalities of a few common disorders in detail now. The first one is myospasm. As all of us know, myospasm is painful involuntary contracture of muscles, and to manage a case of myospasm, normally we follow a three-tiered treatment approach. Self-management therapies like local massage, heat and ice application, and at the same time, lateral pterygoid muscle exercises can be done by having the patient sit upright, gently hold the patient's mandible as seen here. You can see how one finger should go over the occlusal surfaces of lower teeth, and with the remaining 4 fingers, we can hold the lower border of mandible and make him open as wide, just like a corkscrew manner, and let him open as wide as possible, hold it there for some time, close and hold it again in that position for some time. It can be followed by analgesics and muscle relaxants, and sometimes even tongue depressor exercises also are prescribed for such patients. We can, if they are following a tongue depressor exercise, we can tell them that follow a normal routine, 30 seconds each, 6 stretches you do 6 times a day. So a particular routine patient will follow, and it benefits them in such myospasm cases. Coming to temporomandibular joint disc displacement or dislocation with reduction. In this scenario, the disc displaces anterior to the condyle, and is in very rare cases, it goes posteriorly also. Anterior disc displacement with reduction has a good prognosis with minimal intervention. The definitive treatment approach in these patients is to reestablish a normal disc-condyle relationship. The treatment goal is not to recapture the disc. We always have to remember is to provide relief to the patient and to reduce the intracapsular pain. Because here, in such cases, the most common complaint that the patient will come to us will be one opening and one closing click, pain may or may not be present. So we have to evaluate whether it's opening click or closing click, when exactly it's happening, at what extent of mouth opening it's happening, since when it is happening, and then accordingly we have to plan our treatment. So this is the definitive treatment plan for such patients. There is no good standard treatment for clicking as such, but conservative approach is the first choice. Now coming to this definitive treatment, how exactly we follow that. Patients first we give stabilization appliance, and then we follow the patient. If the patient becomes comfortable with stabilization appliance, we can continue with stabilization appliance, slowly wean it off and leave it. In some patients, we see that the patient will be benefited with anterior repositioning appliance. So we first give anterior positioning appliance. Gradually, we reduce the use of anterior positioning appliance. And some patients just with dental therapy to maintain mandibular stable position get relief. Or sometimes we have to convert anterior repositioning appliances to stabilization appliance, and slowly with the stabilization appliance, the mandible will come back in MS position, that musculoskeletal stable position. And then this is how we follow such patients, a definitive treatment plan. This I would like to show you. This patient, she has a, see how she is opening mouth as we were discussing earlier. When she is trying to open, it goes to one side and again comes back to midline. This is what is happening. So we did see now we told her to just bring her teeth edge to edge, and open. Now she is opening straight. Now there is no deviation, no deflection. She is opening straight. The midlines are matching. So this gives us a temporary diagnosis that she will get benefited from anterior repositioning appliance. This is her radiographic evaluation. One thing I would like to bring it to everybody's attention is, whenever we are going for fabrication of splints, it's always better to locate the centric relation position. Centric relation position, whenever we want to locate, we know Dawson's technique, bimanual guidance has to be there. And you can use anterior deprogrammers also. Many types of deprogrammers are there. I won't go into detail. So what we do in anterior repositioning appliance is, these appliances hold the mandible in a more anterior position than the intercuspal position. So it allows the condyle to adapt to a better condyle disc relationship, because the disc has come forward. So we bring the condyle forward. So a better condyle disc relationship will be forming in the fossa. So first we make a clear resin sheet and adapt it onto maxillary cast. The outline of the appliance is cut off from it with a separating disc, and borders are smoothened. The seating is checked intraorally first. To obtain therapeutic or protrusive jaw position, subjects are instructed to open their jaws fully beyond the clicking point. Whenever he is clicking, let them go beyond clicking point and open it fully, and then close in a protruded position, bringing their incisors edge to edge. The maxillary incisor will come edge to edge with the mandibular incisor. So we mark that point, and then normally 2 to 3 forward, because once it comes to edge, you will mark it on the click, as you can see here. It's been marked. So that will be normally 2 to 3 mm anterior with the intercuspal position. So to evaluate whether you are going in the correct position or not, when the patient is closing edge to edge, you can just check it with the intercuspal position. And then autocure resin is first used for making the anterior stop. Once the anterior stop is established, then resin can be used in the posterior region. At the same time, we also have to remember that the anterior stop should be adjusted so that it provides a stop perpendicular to long axis of mandibular teeth. There should not be any slide. The stop has to provide a perpendicular stop with the mandibular teeth. So no retrusive force should be acting on mandible. Then it's very simple. We just add the resin onto the remaining anterior and posterior regions of occlusal surfaces, seat it in the mouth. So with this, the mandible will be advanced to contact the anterior stop. We have to make sure that all mandibular teeth have they have made indentations in the setting acrylic. So the occlusal surface is then adjusted to remove excess acrylic, and we just finally define the contacts. As you can see here, a uniform contact has been achieved. Now we can appreciate the, see, now when the patient is opening her mouth, it's going straight. So what we diagnosed earlier when we were evaluating and taking the history of the patient is correct. So once she uses this appliance, yes, so once she uses the appliance, and normally we see that slowly we will convert it into stabilization appliance later, depending upon patients, how symptoms are getting relieved, how clicking is coming down, how the pain is coming down. Now, just another case where this dislocation with reduction we have treated. This is the radiographic examination for this patient, and you can see the condyles are going much beyond the articular eminence in this patient. So it's associated with some amount of subluxation, you can see. So in partially edentulous cases like these, anterior repositioning splints are fabricated in a similar manner, except that the edentulous space is filled with resin to provide occlusal stops. This is another case. Now coming to stabilization splint. This patient came to us almost after 2 to 3 months of trauma. He had a road traffic accident, and the swelling on right side of face was prominent. So just to make sure how much time is left, I think we have time. I'll move a little fast. So fabrication of stabilization splint. This patient had swelling on right side of the face for a long time, and in X-rays, no fracture was as such evaluated. You can see. So we we did the examination. We found out these are soft tissue swellings. What is happening, and he had TMD problems. So fabrication of stabilization splint is similar to anterior repositioning splint, except the major difference is that here the mandible will be held in the CR position. The centric relation position has to be determined by the same bilateral manual manipulation, and we have to follow the same technique, or you can use any of the anterior deprogrammers. And after training the patient to guide the mandible in centric relation, the anterior stops are created in that particular position, and then we follow the same procedure. The areas anterior and labial to mandibular canines here, sometimes we preserve as to develop, eccentric contacts. So these guiding ramps that we keep in such cases, here you can see, will have a 30 to 45 degree angulation to occlusal plane, and they allow smooth protrusive and laterotrusive excursions. So we normally tell the patient to use these splints for almost a few weeks, and then we keep evaluating them, and slowly we wean them off. So coming to TMJ disc dislocation without reduction, the definitive treatment. In case of acute disc dislocation cases where reduction is not happening, we first tell the patient to go for self-unlocking techniques. In case these self-unlocking techniques, I'll be discussing about these in coming slides, are not working, then we assist manual manipulation to reduce these discs which have got displaced. We assist them manually so that the disc is captured in the same relation as it was earlier. and then we repeat it with anesthesia and NSAIDs. In case the disc gets reduced, you put the patient on anterior repositioning appliance, and then same treatment as this dislocation with reduction is continued, as we have seen earlier. In some cases, it becomes chronic. The disc dislocation becomes chronic. So in those cases, we go for self-regulation or PSR techniques that we'll be discussing in coming slides. And then we put the patients on stabilization appliances. In case patient symptoms don't get relief, then ultimately patient has to go for surgical option, and either surgically they reposition the disc or go for some relief measures. What I was talking in previous slide regarding the unlocking techniques, the disc displacement without reduction unlocking techniques. If we just teach these techniques to our patients where we see disc displacement without reduction and patient does this, normally sometimes the disc gets positioned to its normal position. It's very simple that just fingers have to be placed ½ inch anterior to TMD, and they have to press medially and slightly posterior. At the same time, they have to move mandible side to side. The second method is just relax, tell them where the temporalis and masseter muscles are, and they just have to relax and massage it. And at the same time, while they are relaxing and massaging these muscles, move the mandible side to side. The third one gives better results but produces discomfort for such patients, and that is that slide the mandible maximally to the contralateral side. Like if you are suspecting right side displacement, tell the patient to open maximally to the left side and then open maximum as much as they can. So such movements lead to recapture of disc onto the affected side. So first we can tell these patients to go for self-unlocking techniques. Now the next one I was talking about assisted manual manipulation to reduce discs. Here you can, as you can see in this picture, we hold the mandible on the affected side, give a downward push, and once you feel that the mandible is getting depressed a little bit, from your 4 fingers that are you are holding the mandible, give a rotation force. I'll show you in this video. See, patient has come with acute problem. This is the mouth opening that the patient has. He's a young patient, and for the first time, the disc has got displaced here. If we leave it like this, it will become a chronic problem. So because he came early to us, we are trying to treat him. Always use a gauze piece whenever you are doing it. First, we are trying with self-unlocking ones, but it didn't work that way. So now I am trying to assist him in order to reduce the disc. See, this is how I am holding the mandible. And with a firm pressure, we have to try and recapture the disc. I have put the patient on muscle relaxant earlier so that he doesn't have much pain and discomfort while I'm trying to do it. Always use gauze whenever you are doing it, otherwise your fingers will get hurt. And once you feel that you have recaptured the disc, tell the patient to come back to edge position and be in that position only. Otherwise, again, you will lose whatever you have recaptured. See, I'm telling the patient to open his mouth from here. The first blue marking is the previous marking which I had. That much was the mouth opening. Because the disc has been reduced now, so he will give a increased mouth opening, and even the deflection of mandible will get reduced. Now I am marking another line, and we can compare that almost because of recapture of disc, the patient is now able to open his mouth fully. So this was about the manual assistance, and manually you can reduce the disc and recapture the disc in such cases which are acute. Coming to TMJ dislocation. In case of acute dislocations, we can go for reduction techniques, that's Dawson bimanual manipulation, and you can activate gag reflexes and do it. In case the TMJ gets reduced, we have to go for preventive therapy and give our stabilization appliance as we talk about earlier. and the TMJ becomes stable. In case there are frequent episodes of dislocation, then there are various ways of treating such patients, like sometimes ortho buttons, or sometimes we teach the patient to reduce themselves so that they don't have to come to us every time it gets dislocated. And then obviously there are some surgical measures that normally our oral and maxillofacial surgeons deal with. Here you can see a patient of TMJ dislocation. This is the normal condylar position. It has come much beyond the articular eminence. You can see here. And now the patient is not able to close mouth. You will have anterior open bite seen in such cases. Just a minute. Give me 1 second. See, here there has been mandibular dislocation for this patient, and how painful it becomes for him to reduce it. So such patients can be taught how exactly they can reduce the mandible. It's very difficult for them to do it themselves. So some basic techniques of reducing the dislocation, if we teach them. See, so in case of acute dislocations, there will be difficulty in mastication and swallowing. As you can see here, again, see, condyles have come much beyond the articular eminence. So in such patients, there will be difficulty in mastication and swallowing. Speaking also may be difficult, and the patient will come in with the drooling of saliva. So mouth will be partly open, and affected condyle you cannot palpate. In obese patients, there will be absence of condyle from glenoid fossa, where in obese patients you cannot make out, but if the patient is young, you can really see a prominent depression that is present. Coming to reduction technique of anterior mandibular dislocation, we normally follow classic intraoral reduction techniques. We place thumb over patient's inferior molars, apply downward force, and guide the mandible posteriorly. That's how we do. This is what we are doing here. You can see. See, anterior open bite, as I was telling you. This patient came to us 3 weeks after mandibular dislocation. He was a laborer who fell down while working in his setup, and mandible got displaced. He was not able to close it. So we are trying to reduce it. Sometimes these problems lead to chronic recurrent TMJ dislocations, where a number of other factors will be playing a role. Here you can see we are trying to reduce it, but unable to reduce it because it became a very long-standing one. So ultimately, some LA and help of oral and maxillofacial surgeons had to be taken care of, and then later it got reduced. You can see now it's reduced. And obviously, to prevent any recurrence, they go for fixation. This is how the final profile of the patient comes later. So coming to the supportive treatment, getting stuck. We go for ultrasound therapy in such patients. It's a passive modality and supplement to primary treatment, what we were discussing earlier. It helps relaxing the tight muscles and muscles which are sore and warm, and it increases the circulation and helps healing. At the same time, we have to follow these supportive treatment in all our patients that we are treating. We have to educate patients not to force open mouth, restrict mouth opening, and decrease joint loading. NSIDs and moist heat and ice applications alternatively have to be taken care of. And ultimately, the passive jaw exercises, the distractive manipulation techniques, and PSR techniques have to be followed. PSR technique or physical self-regulation involves primarily training in breathing, postural relaxation, and proprioceptive re-education. Findings that support the use of PSR for short and long-term management of muscle pain in facial regions, especially in temporomandibular disorders. So with this, I'll extend my sincere thanks to IPS Head Office and Organizing Committee, 23rd IPS PG Convention, for having given me this opportunity to become part of this convention, which is having extensive coverage of topics of academic interest. I also thank our PG students and life members who have attended this presentation. Thank you. Thank you, one and all.
Thank you so much, Dr. Manish. It was really a pleasure listening to you, and I congratulate you and thank you for such a crisp and wonderful presentation, presenting such a complex topic in such a simplified way and with help of so many clinical videos actually. That makes it easy to understand for the students.
Thank you.
Wonderful job done. And the key home message I would like to say for the students that from your presentation, that a careful observation and evaluation of the clinical symptoms could be the key in correct diagnosis and reaching the correct treatment plan. And in most of the times, we can manage most of the TMJ disorder cases by a conservative approach. And one small tip I would like to add, like the patient showed with the edentulous span in between. So a small thing that we can do, we can add teeth in that edentulous span in the splint itself.
Yes, madam. Yes, madam. It will make it more aesthetic.
Thing also when the patient is especially wearing it in the daytime. Wonderful presentation. Thank you, Dr. Manish. And thank you to the organizing team for the wonderful organization and wonderful scientific sessions. Thank you, everyone. Thanks a lot.
Manish, it's a nice presentation as well as nice preparation of slides also. I'm really
Thank you, sir. Thank you, sir.
The organizers, please.
So, thank you, sir, for such an enlightening session. I hope we all have learned a lot from it. Thanks a lot for your valuable time, everyone. Please accept this token of appreciation from our side.
Thank you, ma'am.
Thank you, sir.
Thank you.
Thank you. Thanks for having us.
Yes.